Hello, everybody. My name's Ian Davis. I'm a medical oncologist from Monash University in Eastern Cape in Melbourne, Australia. And we're coming to you from the ANZUP annual scientific meeting here in June 2026 in Adelaide. It's great pleasure and privilege to introduce my friend, Dr. Indranil Malik. Indranil is a consultant clinical oncologist from Tata Medical Centre in Kolkata, India. So welcome, Indranil. Welcome to ANZUP. Welcome to Australia.
Thank you, Ian. It's been a pleasure to be at ANZUP.
Great to have you here.
Yeah.
We've just come out of a fantastic session where you were talking to us about what to do where the evidence cannot be applied and your specific experience in India. Can you tell us a little bit about that?
In India, prostate cancers are generally diagnosed pretty late, and we have to adapt to a system where some of the treatments are out of pocket. Patients suffer some of the side effects of more recent treatments like ARPIs and chemotherapy, and we have to adapt to a system where we can give them the best outcomes without giving them a lot of the costs and the side effects of the treatment. And, in my clinical practice, that's one of the debates that I have on an ongoing basis as to how to best treat a patient given the circumstances from where he comes from. And we've had to, look beyond the evidence and take personalized decisions based on the unique characteristics of the demographics and the background of the people that we meet.
There's quite a bit of disparity between what goes on in the urban settings and in, for example, rural and remote settings.
Yes. Localized prostate cancer is something that we uniquely see in only in the urban setting. And however, we have made good advances in local treatments in this setting, both with good radical prostatectomy and with good quality radiation therapy. So we what we want to do is to optimize these treatments so that they best serve the population that we are treating by giving people fewer treatments if possible and by avoiding as much systemic therapy as we can.
India has a well-past health system, and you've had some creative approaches to reducing costs of health there, but there's still some disparities, obviously, in terms of access.
Yes, yes. I think that the Indian health system works in a way that a lot of the treatments that are there are out of pocket expenses, as I mentioned, and the costs of some treatments are high. Access to good quality local therapies can be difficult for patients who come from the villages, for example, and we have to navigate those choices as we go along. Yeah.
You made one statement that really caught my attention. You said, "We've learned to function without money."
Yeah.
We have a similar sort of problem, maybe not quite the same degree, but can you tell us how to do that?
Yeah, so trial funding is a challenge. There's not a lot of funding for research in general in India. So what we have learned to do in academic centers is to balance, our manpower, balance our protected time or the lack of protected time into focusing on questions that really matter. And one of the things that we keep on doing is that we try to develop questions that can be answered with as little money as possible. So we choose our questions carefully, and we try to answer them in a manner that that requires very little funding in a multi-institutional setting. So we've adapted to that. We've learned how to manage our manpower workforce into working in multiple trials, for example, and try to get as much done with one treatment as possible rather than spreading out the portfolio.
And the quality of research that comes out of India is really fantastic. What can Australia, New Zealand, and even the rest of the world learn from how you've been doing things in this very patient-centered way, looking at what matters most, the theme of our meeting?
I think that's an interesting question, Ian. I think that we need to learn a lot from you. But I think that what we've learned is that we have to be very versatile and nimble, and we need to move with the flow. We need to adapt to the changing or ever changing evidence that is there in these cancers, and try to find the correct questions and then move fast across centers, trying to engage as many of them as possible, and trying to increase or leverage the strength that we have in terms of patient numbers, for example.
It's just wonderful to be able to learn from your experience and to take those into our own planning for how we're going to be working. I really hope that we'll find some opportunities to work together.
Yes, that's exactly what we want to do as well. Yeah.
And thank you so much for coming to Australia.
Thank you, Ian.
Thank you for your contributions to the meeting. It's absolutely been wonderful. Look forward to talking to you through the rest of the meeting.
Same here. Same.
Yeah.
Thank you, Ian. Thank you.